Committee meeting to order. Start with the sheriff.
Good afternoon, everyone, and I'm sorry that we're all back to looking at computer screens again, but we all need to be careful still. So my first position I'm requesting is a budgeted and authorized position for a senior investigator, criminal investigator, and also any backfills to happen for this. Senior investigator Foster pulled the plug and he's enjoying the retired life now. So he's done a great job for us, and he did a lot of work with the narcotics unit, and he's going to be a big set of shoes to fill.
Entertain a motion.
I'll do that. I'll make it.
I'll second it.
Is that you, Rick Square? Or?
Well, it was me, but Ron stole it out from me. That's
Either
all.
one. You can give it to Rick. I don't care.
All in favor?
Aye.
Opposed? Carried.
The second one is to fill a vacant, budgeted and approved full-time jail cook position. One of our cooks resigned. She went on and started her own business. So I'm wishing her all the best in the world.
Okay.
I'll move that.
Motion, Rick Scalera, second.
Second it.
Second, Jim Guzzi. All in favor?
Aye.
Opposed? Carried.
All right, and the third one, I'm looking to fill a part-time clerk typist position. What happened is with New York State, and this is not local civil service by any means, it's New York State Civil Service. They cut us back with anybody over the age of 35 can no longer hold the title of per diem deputy sheriff. We've got one person that assisted us quite a bit and is very knowledgeable with our border safety course. Since she can't be a per diem deputy sheriff anymore and she's not qualified to be a special deputy, we're looking to fill her spot, to get a spot for her to continue our border safety course with us as a part-time clerk typist. We do probably 3 or 4 of these a year. It's a great asset. It's needed and it's mandatory for several things on our waterways. And we are primary on our waterways here in Columbia County, as well as the Hudson River. It's one-stop shopping pretty much for the sheriff.
Okay.
Dave, should this say temporary on the resolution request? I think we talked about appointing her temporary every year, and it would be the same thing where you send the hours over here and we just make sure she doesn't work over that 720 cap.
Yeah, I wouldn't even be close, but yeah, I don't have a problem with that.
Yeah, I think we just need to amend that to say temporary.
Yeah,
And then every year we'll-
over to 720 because it's an 8-hour course. And if there's only 3 or 4, she's looking at no more than probably 30 or 35 hours a year.
Yeah, let's just make sure it's temporary and then that we reappoint her every year like the rest of the per diems. I just don't want to run into an issue where she's going to have to at some point take an exam. So
Sure, that's perfect. Yeah.
we'll prevent that. Okay.
And we'd also not put her in for an hourly rate of pay because clerk typist is a UPSCU position. So she'd be in at the grade of a part-time clerk typist.
Which is?
I don't have that in front of me.
Okay.
You could just, no, it's okay. You could just put that down as what she is. Just
Okay.
put it just as it's going to be a UPSCU job. So.
Okay.
Okay. So as amended, do we have a motion?
I'll make that motion.
I'll second it.
On that, all in favor?
Aye.
Opposed? Carried.
Thank you very much, everybody.
Okay, next, Jack Mabb, Health Department.
Okay, so I have a vacant public health technician because somebody who spoke just before me stole away my public health technician. So I do have a vacancy. He was a good one, and he's going to be a great deputy. So I have a need to fill this position. It's obviously budgeted and whatever. So
I'll move it.
Motion, Rick Scalera, second.
I'll second it.
Jim Guzzi, all in favor?
Aye.
Opposed?
Aye.
Carried.
Okay, so we have a vacancy in our immunization program. As you know, our immunization nurse who took the lead in all of our pod productions left us, and I have a really great candidate who is going to be really terrific, but also is young. I mean, we have a very an aging population here, if you will, and this person can be part of the future of the health department. She has a master's degree and qualifies to be a public health nurse or in that title. So I want to abolish the regular nurse position and create a public health nurse, which will cost a little bit more in terms of on an annual basis. But she's going to be great in terms of filling that role.
What's the difference, Jack, in price, just roughly?
To be a public health nurse, you have to have a bachelor's.
Okay, no, I mean, salary-wise, what was the difference?
I think it's
$11,000.
It's on the screen, Jim.
okay. There it is, 11,000.
Oh, all right, I see it. Yeah.
Ron Caponera, that's not an issue?
No, man, it's not an issue.
Okay. So we need a motion?
I have one quick question. Is it an issue in reference to anybody else looking to compete for that position? Or is she the only one that fits the qualifications?
I have two public health nurses within the department. I have no other nurse that's close to having their bachelor's, so they wouldn't be qualified to seek the position anyway. You have to have a bachelor's degree.
Okay. So we need a motion?
I'm sorry, what?
We need a motion.
Oh, I'll make the motion.
Second?
I'll second it, Matt.
Okay, all in favor?
Aye.
Opposed? Carried.
And so we created a part-time clerk position using ELC funds that the state is handing down. I have that funding through March of 23. We lost the original person in that position was doing contact tracing and helping putting folks in the computer as far as the COVID positives. Things declined. She got kind of bored in the position. She wanted something that was a little bit more involved. She took another position. We didn't fill it right away because we didn't feel like we needed. Now that we're heading back into the pod season with our drive-up booster shots, this position could be critical to assisting in our immunization department, putting people in the system and whatever. So we want to fill it. It's grant funded. If I don't bill for it, I don't get it. So it doesn't come out of the general fund or whatever like that. So it really could be a very valuable position for us.
I'll move that.
So we have a motion? Second?
Second?
Second, Ron, Knott. All in favor?
Aye.
Opposed? Carried. Thank you, Jack. Next is solid waste. Jolene
Actually, Wendy's here, I think.
or Wendy? Okay. Wendy, you're up.
I think you're muted, Wendy. Is that right?
Hi all. Our first position up is solid waste to fill a part-time labor position due to a resignation.
I'll move that.
Motion,
I'll
Jack.
second it.
Second, Ron, Knott. All in favor?
Aye.
Opposed? Carried.
And then our second one is for permission to fill a motor equipment operator 2 position, our MEO 2. This is also due to a resignation.
I'll move it.
Motion, Rick Scalera.
Second?
Second, Ron Knott. All in favor?
Aye.
Opposed? Carried. Okay, thank you, Wendy. Next is public defender. You're muted, Shane.
You think I'd pick up on that by now? Good afternoon, everyone. My first, I'm asking, I have a pending retirement of a part-time assistant public defender in January of next year, and I'm seeking to abolish that position and create a full-time assistant public defender position for purposes of family court. That would be 100% funded by an ILS grant. And the position, the part-time position I'm looking to abolish pays approximately $62,945. That's the annual salary plus fringe, I believe. And that's all. The vast majority of that part-time position is paid directly by the county. So there would be a savings to the county in regards to that transaction.
Okay. Motion,
I'll move that.
motion, Ron Knott, second, Jim Guzzi. All in favor?
Aye.
Aye.
Opposed, carried.
The next resolution is I'm requesting permission to fill a family court attorney position of assistant public defender, which will become vacant this Friday, September 17th, due to the resignation of the assistant public defender. Again, this salary is paid 100% by an ILS grant, including fringe. And the starting salary is $70,000.
Okay. Motion,
I'll
I'll
make
make
it.
that motion. All right.
second,
Second.
all in favor?
Aye.
Opposed, carried. Hey, Shane, just out of curiosity, the public defender that's leaving or retiring, what's their salary at?
The assistant public, the part-time assistant
Yeah.
public defender, 61,710, I believe.
Okay,
And that's the vast majority, other than let's see, other than about 5,000 that's paid a pay parity grant by ILS. It looks like 57,986 is paid by the county.
okay.
And Chairman, I just since this is kind of my first run through the budget process as far as adding a position, is this the appropriate form to deal with the proposed raises I had put in the budget workshop last month, or is that
No, it'll be through the budget process.
that would be later on then?
Yes,
Okay, very good. That's all I have then. Thank you.
thank you. Next is facilities. I believe Joe Loeffler is on.
That is correct. We're requesting to fill a maintenance worker position, a grade 11C, due to a resignation and any vacancies that may be created due to the internal promotion.
I'll move that.
Motion, Ron Knott, second.
Second.
Rick Sclera, all in favor?
Aye.
Opposed, carried.
Thank you.
Thanks, Joe. Next is Bob Gibson, Commissioner Gibson, I'm sorry.
I prefer Bob. Thank you. So my request today, I have a part-time transportation aide, been with me for a few years. And I brought some of those on over the years to sort of make up for the different scheduling. Because when I first came on, my drivers worked 8 to 4. So I made some shifts, and new drivers coming on have a more flex schedule, and part-time drivers add that much more flexibility. But there's a lot more weight coming down now on my transportation department. Though I try to stay away from cabs as much as I can, even when I have to use cabs now, sometimes I can't because local cab companies are just They're not taking calls after certain hours. They don't want to go to certain places. So what I'd like to do is take that part-time position and make it a full-time transportation aide. As at least some on the committee will recall, there's more than enough money to cover that through my vacant positions for the remainder of the year. And I have quite a bit of savings built into my 2022 budget and beyond that would more than make up the $20,000 in addition, which is essentially the bump from part-time to full-time. So it's more than made up for the money that I already have in my budget. I guess is what I want to say, and it's an imperative that I bring on that I make this a full-time position.
I do know that we've had conversations about you having a hard time finding cabs now, especially with COVID.
Is this going to be an issue at night, Bob, for you? I mean, this person's going to work during the day, I presume. Is that correct?
Well, this person already works a flex schedule, which is nice. So at this point, I'm trying to cover roughly around 6 in the morning into the later part of the night, 9 or 10, and through flex driving I can. Is it a problem? It is sometimes.
Right.
But we're getting better at being able to handle it because of the flexibility we're building in.
Good. Okay. I'll make that motion.
Need a second run out. All in favor?
Aye.
Opposed? Carried. Thanks, Bob.
Thanks very much.
County Treasurer, PJ.
Sorry, trying to juggle a couple of important meetings here. Yes, this is to fill a vacated senior account clerk position. One of the personnel that we brought up from the mental health office has now accepted a position, open position of in the tax department. And so actually this is just a replacement for her position, and it's actually budget neutral.
Okay. I'll make that motion.
Motion, Jim Guzzi, second.
Second.
Dick Slater, all in favor?
Aye.
Aye.
Carried. Thank you, PJ. You can go back to your other meeting.
Okay.
Human Services, Dan Almasi.
Yes, good afternoon, everybody. So what you have in front of you is a request to fill a budgeted vacant position for a behavioral health care coordinator. These are the case managers that we employ, not the therapists, but the case managers, more formally known as a care coordination position. The reason I'm asking for this now is because the Columbia County Department of Health has secured a grant. Part of that grant has monies allocated to provide mental health services to the school districts. We, as the Columbia County Department of Human Services / Mental Health Center, feel we are in the best position to be able to do so. The Mental Health Center is still dealing with some workforce shortage issues. So I've spoken to the supervisor of the Children's Care Coordination Program, and this program was historically and still is to some degree very much embedded and involved in the schools because they serve children. So with the addition of this position, they would be better poised to provide kind of a clearinghouse role districts where the districts could identify the students that need some sort of behavioral health attention as a result of their return to on-site learning. And the care coordinators could either work with that student and family directly, bring them into the care coordination program, or direct them through a referral process to the most appropriate provider within our community. Right now, they all have caseloads as it stands. They're not quite at maximum capacity, but they're very close. So with the expansion of this additional staff person, it would make it a lot easier for them to serve in this additional role and allow us to provide this to the school districts.
Dan, just a quick question. Does the health department grant cover this, cover the full salary?
Jack has mentioned it, if he's still on the call, I'm not sure if he is.
He's still
Yes.
there.
Okay, Jack, do you want to field that one?
So this is part of the $1.5 million ELC grant. We budgeted $300,000 to go to assist the children coming back to school and be able to have services in all the district schools. And I've been involved with this committee for quite some time, and I know it's important to this committee to have representatives of mental health in the schools. So it was a great opportunity. $300,000 is what we're going to be coming to the committee at 4:00, requesting permission to put in place an MOU with mental health and transfer that funding over.
Okay, good. And Ron, you're aware of this, Ron Caponera?
Yes, I am.
Everything's good?
Everything's good with the grant.
All right. So it's cost neutral. I would entertain a motion.
I'll make that.
Motion, Rick Scalera, second.
I'll second it.
Jim Guzzi. Any further discussion?
If I may just add something, Chairman, what I'd like to add is the grant, I believe, is for 1 year only, correct, Jack, in terms of 300,000? But the way I see this happening is through the care coordination program's interaction with the schools, they'll be able to cultivate the referrals necessary to have this individual have a full caseload once the year is over. So, we'll not only be helping, but we'll also be helping ourselves in a sense, get this new hire up to par where they need to be, so that a year from now, they're able to just go with the caseload that they've created for themselves.
Okay. It's 1 year from when it's filled, correct?
Well, actually, what the grant talks about is July 1st. So I suspect that what's going to happen, because this is $1.5 million is a lot of money for us. And I suspect that as the year goes by and our whole response, because the biggest part of that grant is for testing in the school, I think we're going to be able to extend it. I think the CDC is going to allow us to extend it into the following school year.
Okay.
And then, Chairman, if I may, I was asked at my last home committee to bring to, I believe, this work group, the conversation regarding one of our psychiatrists, our lead medical consultant's desire.
Before we do that, Dan, let's vote on this resolution.
Sure, I'm sorry.
So we have a motion and a second. All in favor?
Aye.
Aye.
Opposed? Carried. All right, Dan, I'm sorry.
No, my apologies. I got ahead of myself. So is it okay if we talk about that now, or do you remember what I'm referencing, Chairman?
At this point, would it be more appropriate to talk about it at the home committee meeting?
Well, it was at the last month's home committee meeting. There were some questions about, the finances of his request. He's looking for an increase, our lead medical consultant, what we would commonly call a medical director. And at that meeting, it was suggested to bring it to this meeting. I feel a bit better prepared to speak more eloquently about the nuances around his request, which I can do here or I can do later on.
He's a consultant, correct? He's not a employee?
Correct.
So it should go to Health and Human Services, not that, this is to fill positions, so.
Okay.
Well, you wanted it in the budget part, Chairman, the budget discussion.
Yeah, which is not this particular meeting.
Okay. So.
Well, go ahead. I mean, you might go ahead and talk about it and then we'll.
Well, okay. So here's the ask. I'll start with a little bit of history. So Dr. Carlos Valle was brought on several years ago now, maybe 5+ years ago, as our lead medical consultant. He couldn't be titled as a medical director because he's not an employee of the county. So we had to label him a lead medical consultant. He's on board with us for a base rate of $175 an hour. Now, I believe it was two years or so ago that he asked for an increase because he wanted medical coverage. He wanted health insurance. And as a way of helping him purchase his own health insurance, we raised his hourly rate to $188.50 with the expectation that he would hit the mark of generating $123,000 annually of revenue. So now he's come back to us 2 years or so later and saying he'd like to be brought up to industry standard for a psychiatrist of his stature. Keep in mind, he is both adult and board certified. Adult and children's board certified. That's like finding a unicorn in terms of psychiatrists. It's very difficult to acquire someone that has expertise in both of those specialties and board certification. So I know it sounds like an inordinate amount of money when we talk about an hourly rate of $200, but that is correct. He is accurate. It's the industry standard. In fact, it's below industry standard. So now that he's asking for the $200 an hour, we are increasing what it is we expect him to produce in revenue by roughly $12,400. So the expectation now is $135,000 is what we expect him to generate.
No, not true.
So just to give you a sense in terms of the history, it was in 2020 that he generated, working 3 days a week, 21 hours total, he generated $130,000 billable services. Through August of this year, he's already billed out $131,000 in billable services.
Ron, what did you mean? It's not true. I didn't
That's
get
not
that.
true, because when you say billable services, Dan, this is my problem with your next resolution. It's gross. You got to net it down to allowances and net reimbursement.
Right, that's there too, Ron, isn't it? For example, for 2020, I think it whittles down to like $140,000, correct?
Well, I don't know the numbers.
Oh, it's part of the package. I don't have it in front of me, but
It's got to be net revenue, not gross revenue, gross charges. That's the true figure that he brings in.
All right.
And the second thing, if I recall, who pays his malpractice? Does he pay it, or do we pay it, or does he?
I'm not sure, to be honest. I can find out between now and next meeting.
Yeah, because that's a big nut.
I remember that being a discussion a few years ago, and I thought that's why we upped his pay so that it would cover his insurance that he was paying it himself.
That's what I thought. Yeah.
I believe he's paying his own malpractice, but I may be wrong.
Yeah, that's what I thought it was the malpractice.
Yeah.
Okay, so
I don't think we cover malpractice, Dan. I know we cover your clinician, but I don't think he's a named provider under our insurance. I'll have to double check with our insurance company. But
the way I remember it is he wanted health insurance, and that's what this is how we helped him get there, cover the cost of his health. I could be wrong. I wasn't directly involved. This was done under Michael Cole's tenure, so I wasn't as intimately aware of it. But just to back up, so in terms of what we took in the door in 2020, it's $144,000.
net or gross?
We billed 190, we took in 144.
All right, so your charges were 190, you took in 144.
Yes.
Okay.
Okay, I mean, we're not going to vote on this at this point in time, but it's good for us to know going into the budget.
I appreciate that. I just want to leave you with this final tidbit, if I may. Moments before signing on for this meeting, I was approached by our part-time psychiatrist who is a county employee, who told me she will be retiring in mid-November. She has not submitted her letter of resignation, but she will be as of tonight or tomorrow.
Boy,
yeah. And then just to add to the pile, we have another nurse practitioner who has been, and this has been going on for almost a year since she returned from a medical leave. She's been using her accruals to make it so that she only works 2 days a week. And once the accruals run out, which will be in December, she will be retiring as well.
Okay.
Okay.
just the bearer of good news. All right, is there any other questions for Dan?
No.
Dan, thanks.
So Chairman, do you want me to represent this at the Health and Human Services Home Committee? Or-
Yeah, you can, I mean, the request that you put in, is this immediately or is this for next year's budget?
Next year's budget, his contract sunsets in December, but we presented the resolution last month just to be proactive, just so, you know, I could reassure him that we're all good. So we have time. I believe we'll be meeting, you know, October, November. There's no home committee in December, correct?
Correct.
So,
So, yeah, again, I think this would be part of our budget process. And we, you know, as we work through this, we'll probably have some additional questions. You can get us additional answers to that process. So I don't know if it's necessary, other than maybe to follow up and say that you talked with the budget committee today, and you know that you'll be working on this as part of the budget process.
okay, very good.
All right. Anything else?
Yeah, Matt, I usually print out the sheets, you know, but I didn't this time because I was running late, you know, to look at them a little bit. But under the public defender, I don't know if I didn't get this right or not, but his salary used to be 62,945, and I see you did, because I was just going to ask also, why did it go to 70? Am I missing something, or? I know I should have asked this question when Shane was on, but I don't know if I missed something or.
He's taking a part-time position and abolishing that to a full-time position. And what's, I'm sorry?
No, I said he's making it full-time, right?
Right, and he's bringing it in at the lowest full-time rate of 70.
Okay, all right, thank you. Okay.
Okay, any other questions or comments? Motion to adjourn?
I'll make it.
Second, Ron, Knott, all in favor?
Aye.
Opposed? Carried. Thank you.
Yeah.
meals and transportation and personal care and so many other things, with the types of checkups that you can do either in person or through a technological platform, such as your previous speaker was talking about, through telehealth, so that there are cross referrals that are be able to be made. So in other words, if there's an OFA client that could really benefit from those interactions using the technological platform with the hospital, with the emergency room on a technological basis, or a physician, that can be done. And there's also going to be individuals identified that are not part of the OFA that are going to need the kinds of services that the OFA provides, like home delivered meals or personal care and so on. And so, why I'm really interested in this is I've been doing this work for 30 years, started as a case manager, and now, run the state office. This is exactly where we need to be in terms of addressing people holistically, not having, individuals who are responsible for a variety of different aspects of care, not talking to each other, not coordinating. And that's where people fail. And we want to make sure that older adults, their caregivers and family members can provide the types of supports that allow people, frankly, and simply to age as independently as possible for as long as possible in their homes and communities. So the funds that I'm willing to put forth and have committed to Kevin would potentially provide some staff support during this 18-month pilot. And then if there are referrals made outside of or in addition to, such as buying technology, subsidizing technology, adding additional meals, adding additional hours for personal care, or taking on new clients because of the referral pathways that are going to be two-way between the clinical side and the non-clinical, which is Kevin's side, that he has the resources to do that without you guys having to put up those dollars. At the end of the day, the metrics, the data, that's what I'm really interested in, because these are the types of things that the nation is looking to embrace and replicate. And I'm certainly looking to do the same in New York State. And again, because of my faith in Lou and his team, my longstanding relationship, also with Kevin as well, and with Becky and this board, this is a really good spot to lend our support towards something that should have been the future 10 years ago, but it's here now, and we're 100% behind it.
Thank you, Greg. Are there questions for Greg at this point? Sarah? Sarah, you're muted.
Sorry. I wasn't at the last meeting, but my concern is always that this all sounds great, but our problem has always been the connecting person to the person that needs help. Let's say if I need help, we're just trying a new program now to get aides, and we're going to pay them more money. But it's always like everybody has these great ideas, depends on that aide, that people only want to pay them minimum wage. Now we're going up to $18 an hour, but I want to see from you, I need to be feel that the help is actually going to get to the person and not get just used up by all these middle people. I mean, I see Mr. Pirro here, and he has a law firm that specializes in elder legal advice, which I haven't been to him yet, but I'm sure I need. But I want to make sure that the care is actually getting to the people, and I don't see that yet.
Yeah, Ms. Sterling, I think that's a great point. The funds that we are putting forth, so there's a large budget to this, and Lou can talk through that part of it, as well as his relationship, his elder law firm, to this project, which really does have a wall between it. The funds that I'm going to provide will do exactly what you're talking about. They will only be able to be utilized, and we will be working with Kevin through his vouchers to assure that. So you're exactly right. The number one problem across not only New York State, but the country is the lack of aid. So you could certainly use some of the dollars that I'm going to put forth to help subsidize the hourly rate, or however you want to do that, to attract aides. That is the number one issue for people not being able to get care, and why we have waiting lists across the state is the lack of aides. But it's also a variety of other things that Kevin and Michelle and their team are going to be able to identify that will only be able to be used for services. These will not go into any other pot except for the Office for the Aging. So I'm completely with you on that. There has not been a part of this budget that was for that. The rest of the budget is really organizing a lot of the other pieces, and where we come in and where our support is Kevin and Kevin only in terms of the larger project and making sure that the services that are needed and identified by the case managers or referred from, a hospital discharge planner or physician's office can actually be put into place through Kevin's office. And so that's where kind of we come in. And let me turn it over to Lou really to talk about, his practice and the relationship between the project, which again, does have a wall between it, because the goal is not to identify Columbia County residents and provide a pipeline to an elder law firm. This, Lou has been doing this type of work for a very long time. There are many, many physicians' offices and other elder law attorneys that saw the writing on the wall years ago that creating, comprehensive case management within their client base has good outcomes. And I think that knowing him for over 20 years, and certainly he can speak for himself, I certainly trust him or I wouldn't be involved in the pilot. And I think that there's been enough put into place to reduce maybe some of yours and others' angst in that regard. So Lou?
Just one quick question about that. We can't get our aides certified either. We can't even find a certifier around here now. So please
Well,
put
that's
that on
something
your
I can
list.
certainly help you with.
Thanks.
Sure.
Thank you, Greg.
Lou, you're muted.
There we go. Can you hear me now?
Yes.
All right. I want to thank the board for giving me an opportunity to come back and discuss the pilot program that we are working on. I want to thank Greg especially for putting not only his words, but his money behind the pilot. It's a real boost for us and for the county office for aging to get the additional help for seniors that's needed there. This pilot program literally has nothing to do with the practice of law or legal services. There's not one shred of legal service in anything that the pilot will be delivering to people. That's not what this is about. My practice is elder law, but what I've learned over the years is that elder law isn't enough to keep people afloat in the community. And so what we're working on here is a pilot to bring technology and social services and counseling through advocates and care managers into the home of a number of different individuals. I had the good fortune of running into my friend from Hudson, Rick Cummings, who's also on the call today. And Rick is on the board of a very unique organization called the Home for the Aged. And I told Rick what I was working on, and he said, that may play to what we're trying to do at the Home for the Aged. And if you recall, the Home for the Aged had a facility, and they ran an assisted living facility on Union Street in Hudson for over 100 years. But it came to the point where they could no longer run that facility and provide services to seniors in Columbia County. So Rick and I talked, and we came up with an idea to bring, instead of the Home for the Aged, virtual homes for the aged into Columbia County to fulfill the mission of that not-for-profit. And at this point, I'd like to introduce Rick and have him talk about the HFA mission and how this fits into that mission. Rick? Is Rick with us? I saw him on the list.
No, he's here, but he's muted.
Rick, you're going to have to unmute.
It's in the bottom middle of your screen.
Perfect. Thank you for the tip.
Yeah.
I'm a Zoom guy. But thank you, everybody, and thanks for having me on the call here today. Yeah, I would second what Lou said. I am Rick Cummings. I'm a trustee on the Home for the Aged board. A brief history of our mission. We were founded in 1883, kind of in the midst of another healthcare crisis at the time in Columbia County. there was a problem. There was an issue with so many husbands and sons going away to the Civil War that we found that the elderly widows that were home really had, there was, of course, back then, no safety net and nowhere to go. So born out of that crisis became the Home for the Aged. And for years, we ran a brick and mortar facility on 7th and Union until the logistics and the constraints of doing that just became too much for us. Since then, we've been a philanthropic organization with our mission to help the poor and aging population of Columbia County in any which way we can. Frankly, that is proving more difficult than I think we maybe initially imagined. And consequently, we were looking for a way, how can we sink our teeth into this? Because we felt as a board, we were kind of nibbling around the edges. We have a fairly substantial endowment. You can only do so many bus trips to Fenway. And we were having issues feeling that we weren't really fulfilling our mission. And then lo and behold, I'm speaking with Lou, and this concept of Everhome Columbia pops up. And to us, after fairly rigorous amount of due diligence, we put poor Lou through the ringer, and because there were some skeptics on the board. But lo and behold, we have really come to see this as our future, as a caring, beneficial organization. Again, as Lou mentioned, what we're envisioning is a virtual home for the aged, where there is no physical plant, there's no brick and mortar, but we can provide services that heretofore were not available to especially rural customers, but through technology and advances in technology, we can now deliver it to them without the need for them to come to a central location. So for us, it was like an epiphany. This is the direction forward for our organization. Consequently, we've made a substantial investment in going forward in this. We've made an investment not only in setting up the project, but we've committed to at least a couple of years, and what we plan on is indefinitely. Once the pilot is up and running, this will allow us to yearly make contributions that will allow people that perhaps can't afford the technology or for whatever reason need assistance. We can then at that point come to them and provide the financial means for them to benefit from this new technology. So we're very excited at the Home for the Aged. I mean, this is kind of a renaissance for us. It's a rebirth. I would hope and pray that the county gets on board with this, because we all know the problems, and I won't bore you with the aging population, especially in a rural area. There's so many problems and so many hurdles, but at least to my mind and our board's mind, Everhome Columbia is the closest thing we've seen to solving these issues. So we're on board 100%. I thank the board for their consideration. If you have any questions for me, I'd be happy to answer.
Kathy, you had a question.
My question is for Greg. How do you propose, because you said you could help with that when they said about the staff, how do you propose to get staff for this?
Well, the question on the table was lack of availability of a professional to certify home care aides. I have lots of partnerships in the state. I can identify and send folks down, or however we arrange that. So whether that be through the Home Care Association or the State Department of Health, that's something I can help with. The identification of people, that's up to you guys, and that is going to be dependent on hours and salary like any other job, no different than, competing for Cumberland Farms or Stewart's. And so, I think the move that you guys made in your budget to, allow up to 4 part-time home care aides. That is the future of aging. We now have, and again, Becky can speak to this better than I, back in the day, every county hired directly personal care aides. All of them got out of the business for one reason or another, but we have 10 counties that, including yourselves, that are getting back in the game. And that's something that I'm interested in seeing expanded statewide for exactly the reasons that Ms. Sterling had raised and others. It's the number one reason why people can't stay home, because they don't have the workforce. And I think you guys made a really smart move in doing that directly.
Supervisor Mussman?
This is a lot to take in a meeting today, and I think there's a lot of components and pieces to this puzzle that I would like to know more about. I think it's a great idea. I think there's a lot of issues, like how does it fit into the Office of Aging here in the county, and who are you bringing in to help with the Office of Aging staff, and where is all this, where are the funds placed, and how is it all working out? I mean, it seems like, just to sort of speak on this off the cuff is a little, it's like a very complicated project, and I would like to see more details and know more about how it's going to actually work in reality. I mean, we have a lot of hurdles. We have, just technology and learning it in our community is a struggle. We have broadband that's still risky, and I'd like to see the details of how this can happen and how it can all be in reality come to help our community. So that would be helpful, and then maybe present it to the whole board, because it seems like a lot for just one committee to take on. Thank you.
Michelle? Graham?
I just wanted to mention that I was able to find an agency that will train the aides, Accent Health, out of Troy. And I spoke to them last Tuesday and Wednesday, and they do training at the beginning of every month. So we did finally find a place. Thank you, though, Greg, for your offer.
Thank you. Brenda?
Yes, and this question is for Mr. Olson. How does this compare to the virtual senior citizen project?
So it's completely different. What the VSC is, for those of you that don't know, we have a couple of projects that we have launched either regionally or statewide to bring technological platforms, senior center without walls, other types of programming, not just service programming, but things that matter to people, right? You like to cook, you could do that. You like to quilt. So that brings really technology into people's homes that obviously have the technology and the capability to use it, primarily to stay connected and to combat social isolation. What this project really does is holds hands and integrates clinical care with non-clinical care. So I'll give you an example. You wind up in a hospital. Part of the discharge plan is you're going to need home delivered meals, personal care for a certain amount of time. You might need transportation to a follow-up appointment or a primary care physician. Those are the things that we would fund if they're not an OFA client, Kevin and his team to do. On the flip side, there might be monitoring that needs to happen as part of that discharge plan, where the technological platform that Lou and the Home for the Aged have really put together can interact with clinical care and non-clinical care. But frankly, folks, the big lift is always when people get home. What happens when people get home and who's there? If there's nobody there, they're going to wind up back in the hospital. They might be spending down to Medicaid and wind up in a nursing home. And I think why we're so excited about this is the ball we've been pushing up the hill for the last 30 years to really demonstrate the efficacy and value of what the Offices for the Aging do in supporting healthcare. And so if Lou and Becky can kind of chime in from the clinical side of how they kind of see the pathways, working, just as a couple of examples, I think it would help, crystallize this a little bit more in your mind. Because I understand when you first hear these things, it seems complicated. If you don't do these types of things for a living, and parts of it are, but it's a lot more straightforward than you may suspect.
Lou, can I ask a question before you start, please?
Sure.
Just to add to Greg's point, can you just walk us through, as Greg just said, you have Mrs. Smith, she just gets out of the hospital, she needs 6 or 7 different things. You guys determine that she would be a good client for you, whether the OFA gives her your name or you have this as a client. Tell us how this exactly works and what you would be doing from day one. I think that would be helpful.
Sure. And Greg mentioned earlier that Columbia Memorial Hospital has come on board and we've been meeting with them and talking to them. We're going to do an in-service for all of their social workers and discharge planners. Their meeting is in October. I think it's October 8th. I could see if they would open up an invitation to any or all of you that might want to attend. But we're going to work on this from both angles. If you take the case of Mrs. Smith or my aunt who's in rehab right now, who I'm a caregiver for, I use her case all the time. She's trying to go back home. Fortunately for her, we had the system in place in her home, which is right in Hudson, before she fell. And she fell in a shopping mall on an escalator at 99 years old and is in rehab right now. So she went through the hospital, is going through rehab. We have a social worker who is helping to coordinate her care with the discharge planners at the rehab facility. And in her home, we've installed technology. So there is a sensor system, a camera system that I, along with my cousins, because she has no children, so the cousins are the caregivers, we all already know what's going on in the home. And we're talking to Columbia Memorial Hospital because one of the things that's happening in medicine is a move towards something called value-based billing. And the hospital has flipped to now a full commitment to value-based billing, which it helps the state office for aging and the county office for aging because it's an emphasis on well care and prevention. And so the hospital is now working with us to be their extender into the community so that when a patient discharges, they have certain conditions, heart condition, CHF, or breathing, lung condition, COPD, where they will do remote patient monitoring with certain wearables and things that go back to the home with that patient. But those things are Medicare reimbursed only for about 30 days, and then they get retracted. And then, as Greg said, the person falls again or ends up back in the hospital again. And so what our technology allows, and my aunt at 99, we thought we were going to have to place her 2 years ago, but the technology has allowed us to manage her care in home with very little intervention. She's very independent at 99 years old, and we are able to monitor and care for her from a distance and bring in appropriate care when necessary. So the app that's being developed is going to be the tool that will allow the hospital, the primary care physician, the family caregiver, the office for aging, and the patient themselves in their home to be on a common platform and to be able to share information, share data, and to coordinate the services necessary in the home, both from a healthcare and the social determinants of health perspective, and to bring in the necessary services, but to keep those services to a minimum through the use of the interactive technology. The beauty of the technology that is being designed, and we're not the sole designer, we're integrating a number of different platforms into our app. It's all hands-free. So my aunt doesn't touch a thing in the home. We operate it all remotely through the app from our iPhone. And so it's allowing my aunt to stay independent, not having to look at a placement for her, keeping her in her own home, and allowing this discharge now to be a smooth discharge because we already have all of the services placed in the home. And so the hospital is very interested. Quite honestly, we approached the hospital a year and a half ago, and they sent us out the door because they were at that point a volume producer. They wanted patients going through the ER. They wanted patients into the hospital. They wanted procedures in the hospital. But we've had great conversations with Dr. Pope, who's the head of the community-based medicine at Columbia Memorial, and they are now fully committed, as I said, to value-based billing. And the value-based payments come from keeping people out of the hospital, preventing readmissions, and promoting healthy aging in the home. So it's a sea change, and it's a phenomenal thing. And it really plays into the whole concept that Greg is espousing. And at this point, I want to bring Becky on because Becky is the head of the statewide area agencies on aging. But more than that, and she can tell you her background, she's been in this game from the inside as a social worker. Becky?
Thanks, Lou, and thanks to the full board for having this meeting. And, I really appreciate the very thoughtful questions that all of you raised. I know this is a lot to take in. I'm going to take a quick step back. I have the privilege of representing the 59 offices for the aging throughout New York State, which Columbia County, Kevin and his team are an integral part of. And really, when you talk about this concept of holistic care in the community, it's visionary in the sense that we're actually doing something that CMS tried to do about 5 years ago. I'm sure you're all very well versed on the Human Services Committee as far as the DSRIP initiative, value-based payments, keeping people out of emergency departments or acute care settings. And this is exactly the type of model we're trying to do across New York State for a couple of reasons. Number one, the changes in Medicare. Obviously, you can't go to an emergency department or get admitted to an acute care facility unless you are very, very ill. So people with chronic conditions, as Lou spoke to and Greg spoke to, we're serving people that, and Kevin's serving people that meet skilled nursing facility criteria, right? They have chronic conditions, they're very frail, they have a lot of complex medical needs, and they're no longer able to access either skilled nursing facilities or acute care facilities for really that hands-on care that's necessary. So what do you look at? You look at community-based care. And part of what Columbia Hospital looked at, which is happening statewide and in the nation, is how can we make sure under a value-based payment contract that we're providing home care services for these patients instead of fee-for-service, come to the ER so we get paid. So obviously, the hospital has identified they're no longer going to be able to be paid based on volume. They're going to be paid based on the health of their patients in the community. So who do you turn to as far as those non-clinical services that support people? So the buzzword is social determinants of health. It's all of those things that Kevin and his team provide. It's the meals, it's the daily safety check, it's the personal emergency response systems that are in homes, it's the case management services that his staff provide. So how do we marry those services with clinical services to ensure that people are able to age in place, which is good not only for your county, it's good for the state, it's good for the federal government as far as Medicaid dollars are concerned. So although this is kind of a big idea to kind of look at, it's exactly what we're trying to do across New York State. And I can share with you, we're looking at this in pockets of New York State where we have either funding available or philanthropic gifts that we can use to leverage. And really make sure that we can do these pilots, gain data, which is going to be beneficial for our network overall. Lou referenced this, Greg did as well. Prior to coming to the association, I ran a AAA, so I was in Kevin's position in upstate. And then prior to that, I was an acute care social worker at a medical center. And this is exactly the type of service that we look to coordinate within the community. I think you raised a lot of really good concerns as far as the direct care workforce. As Greg mentioned, this is a huge issue in New York State. We're lobbying and advocating on a daily basis to increase the wages for direct support professionals. But at the same time, we're looking at how we can marry the actual hands-on provider with all of those wraparound services that overall impact the health of your community, which is beneficial not only to your county, but obviously to the state as far as keeping people off Medicaid rolls in their homes and communities. And so, I look at this, and I've spoken with Kevin and his team and Lou and Greg to really leverage a small rural county that can embrace this idea that we can, partner with private dollars as well as state dollars, and then get metrics behind it to then go to value-based contracts, which essentially is what New York State, all of the offices for the aging are looking to do, to be able to instead of depending on federal and state funding, we can then generate revenue through either health insurance plans or value-based payment contracts for the very important work that we do that you all support so significantly financially at the county level. And so I'm really excited just in the sense that, we have a great county. We have an opportunity with private and public dollars to really launch a program that is going to take, at the end of the day, it's great to talk about a pilot project, but if you're the individual receiving the service who just got discharged from a hospital, you may, lack family caregivers, and you have this whole telehealth support network through your local office for the aging, your health outcomes at the end of the day are going to be much more significant than someone that doesn't have those services. So the potential for this opportunity to really prove we did this in Columbia County, the hospital was on board, the state was on board, the county was on board. And this is, you know, a year later, what we found as far as metrics, I think is just an amazing opportunity to really show not only the value of the older population and why we need to support them, but also how, you know, we need to look at a different way of providing services, because the current clinical and social models that don't communicate with one another aren't being successful in the community. So, you know, I really appreciate all of your time. And I think this is a really great opportunity for us to really make some change.
Can I just add quickly? I'm sorry, I don't mean to jump in and take time, but I think one of the questions on the table is what's the role of the office, Kevin's office? And so I can simply put it this way. If your caseload, which it is, because I'm looking right at it, 85% of the folks on Kevin and Michelle's caseload have 6 or more chronic conditions. So you're talking about hypertension, diabetes, COPD. These are exactly the types of people that you want to make sure are connected to their primary care physicians to be able to manage those things to keep them at home. So the idea is this isn't for every person over the age of 60 in Columbia County. It's for those individuals who are at risk that can utilize this partnership to make sure that they are served holistically. If Kevin and Michelle and their team identify somebody like that, it's not like they are going to be giving a list of people to some entity. It doesn't work that way. Older adults, like anybody else, have the ability to make decisions. And so if it's somebody that I started in this field as a case manager in an office for aging. So if I identified somebody who I thought would be really ripe for this pilot, given their risk level, their functional level, their chronic conditions, they would need to provide consent in order to participate. If they choose not to participate, well, that's their right to choose, and then it's over. But if they choose to participate, they would be somebody who could really benefit from this holistic approach. And, you know, Kevin and his team can make that referral. On the flip side, if it's somebody that's not on their caseload, who is also an individual like I described, who could really benefit from the types of services that Kevin provides, the same type of process would happen. A consent for that individual to be referred over to the Office for the Aging would be provided. And then the funds that I am willing to put up would be able to, again, not using county funds, I'm putting up these funds, provide those services with the entire goal of keeping that person at home. And what are they doing at home? Whether their income is low or not, they are paying taxes, they're buying stuff from local vendors, they're supporting schools, supporting local businesses. Once they spend down to Medicaid, you lose all of that economic activity. And our mission solely is to help older people and their families, their caregivers, stay in their homes for as long as possible. So it really is almost that simple from the OFA side in terms of what their role in this project is.
Matt?
Okay, actually, you took my questions and you went ahead and answered them. And, you know, my questions were going to be, what's the programmatic commitment? And then what's the financial commitment of this pilot, which it doesn't sound like there is a financial commitment by Columbia County at this point in time.
That's correct, Matt. And to both Becky and Lou's point, and, you know, we had talked about this when I came down. I'm sorry, I should have called you chairman, my bad. What I'm hoping to get out of this by putting our dollars forward is the metrics and the data, so that Becky and I and Lou and others that have been trying to do this for decades can actually increase the revenue that comes to Kevin's office that is not always reliant on us. So you guys just passed a resolution on dollars that I got passed and Becky got passed in the budget to address waiting lists. That's where those dollars came from. We've gotten a $53 million investment in our network the last 3 years because we were able to put data behind how effective the services are that Kevin and the rest of the counties provide in keeping people off of Medicaid and in their homes and communities. So there is zero financial commitment for you. That's why I'm here, is not only to support you guys as a county, but to support this real innovative project that I am, again, 100% behind. So there's no financial commitment at all, at least on your side for aging.
Okay, I guess then I would pose the question, if it's a pilot, there's no financial commitment, why would we not want to try it?
I would agree with that question. I think you should, because at the end of the day, we're going to learn something. I think I know what we're going to learn because I've seen metrics from some of the other stuff that we've done, and that's why I'm so excited about it. Worst case scenario is it doesn't work, which I don't see that happening at all. You know, that's what pilots are for. That's why we test things. You learn things regardless of how it goes. But, you know, again, I think Lou's platform that he's really put together an amazing team is so much more robust than anything else that I've seen. And those things that I have seen have yielded unbelievable return on investment. And if at the end of the day, it winds up bringing a couple $100,000, a couple $1 million of additional revenue outside of state, federal resources, that can help you reduce your county match, save you county dollars, and grow these services without having to put an additional dollar in.
Patsy?
Thank you. I might have to use this someday, so I got to make sure. But is it only for, are you only dealing with people from Columbia County that go to Columbia Memorial Hospital?
No.
Let me address that. So, as I said, we're pulling from both sides. We're pulling people who are in the home, who want to create the safety net for themselves. And that's going to be people who are right now just private paying for care, doing it out of their own pocket. People who have means will be part of the pilot program. So there's a substantial component of private pay individuals who are going to pay for their own technology and the hardware and the software. There are also, we're working on now, we don't have it yet, but we're working with the Department of Health to bring Medicaid people in, because we think the same technology is going to save them money on the Medicaid side. So it will service Medicaid patients as well, in addition to State Office for Aging clients. So the hospital is one way to get through this. But remember, the hospital has, as part of its network, dozens of primary care physicians. So when we go on the 8th, we're going to be meeting not only with the hospital social workers and discharge planners, and this is all being coordinated by Bev Turner. I don't know if you know Bev Turner at the hospital, but I've asked her to be on the not-for-profit board as well. And she's very excited about this because her social workers are the ones struggling to get the services for people in their homes. So it's coming from primary care physicians. It's coming from the hospital. We are hoping to get some participation from the Office for Aging. It will come from a number of public forums that we're going to be doing throughout the county over the next 3 months to educate people and alert them to the fact that they have this opportunity to enroll in the pilot. And we've put together what I think is a very strong board. The 501c3 is called Everhome Columbia, and we're working in conjunction with the Home for the Aged, but we set up an independent 501c3. All the funds are running through the 501c3 to fund the pilot. And Rick is participating on that. Bill Gerlach is participating on that, who's also one of the HFA board members. And Becky has graciously offered to serve as one of our chairs of the board. So that advisory board for the 501c3 will be supervising and managing the pilot as it rolls out.
All I ask is that if somebody goes to other hospitals also, that they are entitled to this program also, besides just Columbia Memorial. And I hope the answer will be yes.
Right now, the pilot, because HFA's mission, and they're their funder, their mission is to serve seniors in Columbia County.
Yeah, if you live in Columbia County, no matter where you go, that's what I'm asking.
Right.
Yes.
Greg's mission is to serve people all over the state.
All right.
Yep, and there are so many community points of potential access, whether they be the not-for-profit network, the vendors that Kevin's team deals with. Certainly you guys. I mean, you guys are all involved with your community and have families, etc. So again, it's not for everybody over 60. It's for those individuals who are really at risk, and those identification points can be any and all.
And we will also be working with the disabled population. So adult disabled individuals who are living independently in the community will also be part of the pilot.
Rick?
Yeah, just to put a number on this and to give you a level of our commitment, we're 350,000 in on development of the pilot and $150,000 a year thereafter for implementation. So that's the level of commitment that the Home for the Age has for the program.
Thank you. Sarah?
Yeah.
Sarah, you're muted.
You take
I
a
was
walk.
clicking the hand thing instead, sorry. It got my attention with the fact that you said the hospital has totally changed their attitude from becoming a value producer and trying to make all this money themselves, which is wonderful. And I think then when you say the economic advantages to the county, I mean, I think those two things are huge, as would certainly would change my opinion when you're saving everybody money and keeping my funds to me.
Yeah. I participated in a program that the State University at Albany ran probably 10 years ago. They called it the Aging Prepared Community. And they tried to bring all the stakeholders together in a 4-county area and pull it together and do something like this. They had a 2-year grant. It never really took off. But really what you're doing here is you're creating a safety net for people living in their own homes, allowing them to age in place, allowing their family members, wherever they are in the world, to help out and manage that care, because the technology allows remote child caregivers to participate meaningfully and to be part of the care plan on a day-to-day basis, and to have conversations with their parent by phone, which I do with my aunt. You know, we have virtual conversations. My aunt doesn't touch a thing. I just pop out of her kitchen and we talk. So it's creating a new fabric. And they say it takes a village to raise a child. Well, in today's world, it takes a village to care for an aging loved one. And so we have been so lucky to find the Home for the Aged, to have Greg commit to this, to have the hospital jump in. And this, you know, not to get emotional, but this goes back 20 years. And 9/11 for me was a time I spent with my mom at an Alzheimer's clinic in Bennington, Vermont. I had to drive her up for her meeting. She was in a drug trial. She had Alzheimer's. She lived in Hudson. And there were virtually no services available for her in Hudson, New York. And so that's when I started to think about things differently when I was a caregiver. And that's how a lot of people get involved in this field. And if you haven't been a caregiver, you probably will be at some point. And you know how difficult it is and how you struggle as a caregiver to find a way to meaningfully help your parent or your loved one. And so 20 years later, here we are with technology that is revolutionary, that's available, but there's no way that it's being delivered in a meaningful way. Through the State Office for Aging, through Columbia Memorial, through HFA, we have a way to put this now in 400 homes in Columbia County. It's going to be a pilot that I think is going to get a lot of attention. And I think it is for the county and for every county down the road that adopts it. It's bringing a fabric to the county right now that doesn't exist in aging services, and allowing the county to serve its population in ways that no place else in the country has yet. So to me, it's really exciting. And it's a game changer. And Matt will tell you that how many years ago, Matt, was my father here thumping the table for the county youth hero?
Come on, let's go.
And so I'm on the flip side of that coin.
Brenda?
And Lou, just to jump in really briefly on that, because I think you raised a lot of really good points. And I'm going to take my hat off currently and go back to being a discharge planner. And I can't tell you how many times a discharge plan fell apart because of one of these tiny pieces. So you would have someone that was older who absolutely did not want to go to a skilled nursing facility, but because they had a visual impairment or congestive heart failure and needed to weigh themselves every day to remain in their homes and communities, or because they didn't have a primary caregiver, we ended up transitioning them to a skilled nursing facility. And that's not unique to the Adirondacks where I live. That happens across New York State. It happens in the city every day. This type of pilot project with the technology married to the case management, to the Office for the Aging, is going to ensure that people that don't want to go to a nursing home are able to go back to their homes and communities because we have a safe discharge plan. So when you take the human component of what you're doing for residents of Columbia County, it's just such an amazing opportunity. When you take that lens out and you look at the economics of what we do, we serve people that qualify for nursing home placement on average between $6,000 and $9,000 per client per year versus $150,000 for skilled nursing facility placement. 50% of that comes out of New York State Medicaid dollars. So your taxpayer dollars are going to those Medicaid individuals that are forced to skilled nursing facilities because nowhere has this type of holistic care in the community. And the fact that you have, you know, the Home for the Aged, which so graciously has pledged money to this partnership, as well as Greg and his leadership at the state level, without having any type of financial burden to Columbia County, I just think is an amazing opportunity for us selfishly to be able to go to the rest of the state, to the governor and to the federal government to say, look what we did in Columbia County. Look at the metrics we have 1 year later. Look at the stories of individuals that were able to remain in their homes and communities instead of going to institutional settings, and really set the stage for the rest of New York State to do exactly what they wanted to do 5 years ago under the DSRIP initiative, which was exactly this, but it didn't come to fruition because we didn't have enough time. So, you know, I am beyond excited at the opportunity for this. It's something I selfishly, again, I want to replicate across New York State. I think you guys are a wonderful pilot county to do this in, based on your geography, based on the leadership at the county level, and based on your overall population, which is, you know, you have a large number of individuals over the age of 60, you have a large number of individuals that would benefit from this pilot. And you also have a public-private partnership opportunity that I haven't seen anywhere else in the state. So I'm really ecstatic at the thought of this. And, you know, my one takeaway from this, regardless of, you know, where you land as far as the pilot is concerned, is think about what this means for the individual on the receiving end. And, you know, when I'm at that point in my life, I want to have a program like this to be able to remain in my home because I don't want to go to a skilled nursing facility. And, you know, we really have an opportunity to facilitate some change. So I want to thank all of you for your time and really great questions.
Brenda, you had a question? You're muted.
Sorry, the train just went by. I didn't think you wanted to hear that. I had a couple of questions. Does your work include physical improvements like ramps for people to get in and out of their homes? Would this program include something like that?
It certainly could. That's an allowable expense already under Kevin's portfolio. We do a lot of minor home modifications, repairs, ramps. So that's certainly something that could be financed out of those dollars. I would not be directing Columbia how to spend them. I would rely on and trust the case managers and the care plan to determine that. And then you have the green light to determine what those best interventions are. But that's already allowable under what Kevin's allowed to do, and has been for, you know, since the mid 80s.
Oh, that's really interesting because I worked until recently for another not-for-profit, and we had a tremendous backlog of seniors waiting for ramps. They could not be discharged from where they were until they could get a ramp for their home. And our biggest problem was finding the money to build those ramps, which we raised through private means, but that's interesting to know. So I'm going through a similar circumstance. My mom is 93 and we're wrestling with almost every issue you've had on the table tonight. So I really appreciate what appears to be a pretty clear path forward and a means to address these issues from the family's point of view, as well as from the patient's point of view. So I think I hear two numbers on the table. Greg, you're saying the state's willing to consider, I think, 200,000 for the pilot program?
Yeah, I'm willing to commit up to 200,000. So that's a done deal. I have the ability to do that. That's done if you guys decide to go forward with that. As I mentioned, you know, there's a couple other things. Again, you guys just voted on an $85,000 additional unmet need. Congress right now is looking at $1.44 billion increase in Older Americans Act. I can actually give you the number of what that would be, but it's basically all of your American Rescue Plan money all over again every year. And I'm pushing a $2.7 billion national plan that Senator Gillibrand is carrying for me to basically double that amount. So, I think the issue that you raise exactly right. We have long been starved of funding within the aging network. So it's not that these are things we couldn't do, but you have to make difficult choices. So you give somebody a meal, and how do you budget 12 years in advance on a fixed amount of dollars coming in? So I think the future is really bright for us, to be honest with you. But yes, I've committed up to $200,000 for any staff support during the pilot and any service dollars that would be determined locally by you guys.
So there are two other numbers. I think, Mr. Cummings, you said that your organization was willing to commit somewhere in the range of 150. Is that to Columbia County or to the
No,
the
three
program as a
something he
whole?
was given.
No, this is to Everhome Columbia, 350 to
350.
start the pilot, and then after what we perceive as our future is to be able to utilize the system once it's up and running to provide yearly 150 amounts to needy people as we go forward, and that carries our mission forward into the future.
And then someone else mentioned a number of 400, and it's potentially to help 400 Columbia County residents. How did we arrive at that number, and how many people do we have? I think you, Greg, gave us a number that 85% of Kevin's patients would be eligible for this program. How does that relate to the 85% of Kevin's
So you can
list?
clarify a couple of the numbers. Luke can break down the various pots. There is a Medicaid pot, a private pay pot, and potentially an OFA pot. The numbers that I was referring to in terms of Kevin's caseload is, they have to report to us, all the counties do, through our system of who they're serving. And based on the assessment, we get a lot of robust data. So the data that I was providing are actual people that you're currently serving right now. And it's very consistent across the state. The average person we serve is an 83-year-old female who lives alone, low income, and has multiple chronic conditions. Yours is higher than any other county I've ever seen. 85% have 6 or more chronic conditions. I mean, just imagine that, right? And then multiple functional limitations. And what that means, and I hate the industry language. So these are people that without assistance can't get up in the morning, can't bathe, can't dress, can't eat, can't shop, can't drive, may not be able to pay bills. Those are the types of people that Kevin and his team are keeping in their homes and communities every day, as Becky said, for about $7,000 a year versus about $150 for the same type of thing under Medicaid or in a skilled nursing facility.
My last question is, subject to approval, obviously, if and when this were approved, how quickly could the program be implemented?
We're targeting January 1 as our launch date, formal launch date, and everything we've been working on. We have 5 public forum sessions throughout September, October, November. We have a media campaign that we've planned that we'll be launching to advertise. We'll be going into Columbia Memorial on October 8th to meet with all of their staff and to educate them, and then meet with the primary care physicians themselves, and working with Dr. Pope to integrate us with the technology that's already existing at Columbia Memorial Hospital. So the 18 months is designed to start on January 1. It will obviously take time to roll out. You can't go into 400 homes at once, but it's a technology installation. Part of where the Home for the Aged funds is going to go, it isn't going directly into the budget of the County Office for Aging, but it's going to subsidize the technology for County Office of Aging clients. So it'll be paying the technology costs directly for NYSOFA clients and County Office for Aging clients. And then it will go throughout 2022 and then through June 30th of 2023. That's the 18 months of the pilot.
Yeah, and I just want to be clear that the funds that we are committing would go directly to the county office. They would voucher for us just like they always do. So those would be accessible by the OFA.
Lou, you have your own people that come in and put the technology in?
The firm is General Security. It's one of our contractors. They have an office in Hudson. They work with alarm.com. That's the hub technology that we're installing.
So this
and alarm.com is a national company. They're a large publicly traded company They have a wellness program. You can go on their website. They have some wonderful videos and things of their technology, but General Security will be doing the 400 installations.
Okay, so it's a monitoring system on steroids, basically, which is geared toward home healthcare, correct?
Yeah, with interactive features. So
Okay.
it allows the two-way communication.
Okay.
It allows caregivers in the home to input data. We've integrated the emergency medical services. So PJ Keeler is on the board of the not-for-profit. So the EMS services are all integrated into the service package, and telemedicine is available. So we have something called ER at Home, which is an emergency level telemedicine visit that will be available to people through this pilot in their homes, which is one of the key metrics to prevent that hospitalization.
And is there a piece of this that's actually like a monitor piece that's attached to the individual?
They do have wearables. They have them that both do it in the home. They travel with you. So that is absolutely part of the program.
Because I would assume that you wouldn't want to be visually monitoring somebody 24/7, are you, for privacy purposes?
Absolutely not. There's one monitor in a central location, which is a public area of the home, but the sensors do monitor people. So you can actually count their steps throughout the day. You know when they fall.
Great.
That's the technology.
Terrific. Supervisor Mussman?
Yeah, could you give me personally, I would be interested in who's on the nonprofit corporation and some names. It seems the more you talk, the more partners are involved with all of this. So it would help me to understand the nonprofit, who sits on that board, who sits on, who's involved with your organization. I'm assuming it's private.
Ours is, yes.
And I'm also interested, now I'm hearing that the money that, Greg, you're giving to the county is only for technology.
No,
And
it's the opposite. The money that we are committing has nothing to do with the technology. That's where Rick and his team have really come forward with Lou's team. Ours is for services only. So you need a ramp.
what are those services?
Whatever somebody needs. It could be, again, personal care level 1 or 2. It's going to be case management, transportation, home delivered meals, health insurance counseling. That's, a personal emergency response system if needed. So it could be any and all of those. We put $95 million in people's pockets last year just through health insurance counseling and getting them on Medicare savings program. So it's the direct services that the OFA provides, but it allows for flexibility, just like the $85,000 you guys just approved, where if there's a new need that comes up that's outside of the scope of what you traditionally provide. Like you guys are, I think, one of the only counties in the state that don't have a social adult day program. If you wanted to create that with those dollars, you certainly could. Putting in ramps, doing modifications, those types of things. But those are things that you're going to decide, not me.
So who pays for the technology? Maybe I'm just bleary from all this conversation. Most people in the county can't run their VCR. So I'm just like, want to be, very clear that this is a lot of technology and how is it working and who's handling it. So
It's funny you say that, because when my parents lived in Hudson, I lived in Albany, we figured we'd do them a big favor. We bought them a VCR for Christmas. And every time the power went out, the time would flash and my father would call me up. Hey, can you drive down? I need you to reset the time on the VCR. So the beauty of this is my 99-year-old aunt is being serviced by all of this technology in her home right now in Hudson, and it's working beautifully for her. So Rick's group, the Home for the Aged, part of their commitment, the money that they're putting in, is going to fund the technology installations. And
I did like the idea of having this group do a presentation to the full board at our next meeting. If it's possible, the next meeting, I believe, is October the 13th. And I think, what I'd like to do is, Mr. Chairman, is to make a motion that Columbia County participate in the pilot pending approval by the full board. So at least that we can move it forward then a presentation can be given at the board meeting or prior to the board meeting possibly. So at which time it could be voted on.
I would be happy to participate in whatever you need me for.
Yeah, me too, certainly.
I think that's reasonable.
So we're, it's coming out of here. It's still going to go to the full board for review. But by coming out that we support a pilot via resolution from this committee, at least it can be voted on at the board.
Matt, that will be before they were already have not, they haven't gone to Columbia Memorial yet. Don't you think we should hear about that, how that goes? I think before our board.
Well, if I may, from what perspective, our session on October 8th at Columbia Memorial is a training session. They have committed to the pilot, and we're going in to teach their social workers how this pilot is going to work.
Okay, so they committed fully again,
Yes.
all this.
Yes.
And I think Linda brought up a good thing. Technology with seniors is absolute worst. I'm constantly helping them, and I'm not really good at it either. And I know my mother had a life alert button, and she used to call it because the cable was out. So I think we really need to make sure that you show us how that would work and really talk to our seniors, because I just spoke to our seniors recently and they're not big on technology per se, and they don't understand it. Like Linda said, they can't work a VCR. A woman said, my kid gave us a DVD. We still don't, I've never taken it out of the box. So,
But it seems to me,
Yeah.
Lou, though, that this technology is not, it's more interactive versus them actually having to do much with it. The sensors are put in where they move, it's monitoring them. It's not like they're pushing buttons to tell you how they're feeling or breathing. And if they, so to me, it seems like it's much less technical. It's techie on your end, but not techie on the seniors end. Is that
that'd be nice. That'd be
That's
good.
correct. The technology is, if you think about it, this is the age tech market, which is a very rapidly evolving marketplace. And it's all behind the curtain. So the senior doesn't touch anything, doesn't have to. But me as the caregiver, I take out my iPhone and I can pop on a screen that has all the systems available to me, and I can pop a video button and say, hey, Aunt so-and-so, how you doing? And have a conversation and see her and observe her and have a video chat. She's just standing in her kitchen cooking dinner.
So
by the way, guys, that was our first question to Lou when he came to see us. So
okay.
Thank you.
So again, I'd like to
So
get
it's possible that I could get, could I get the information that I asked for at some point?
I will I'll send you a package. I'll send it to as many people as you want, but certainly to you, Supervisor Musselman, and I will get that to you. Also, we have set up a test facility. It is here in Latham, and I would be happy to organize a field trip. If you want to come in, the technology is installed. We have installed a whole bedroom set with the technology in a unit here in a facility in Latham. And I would invite you all up for a field trip to see exactly how the technology and the app works out in the field. So, and I'll put together a package with regard to the not-for-profit board and also some of the materials that we've developed that we'll be disseminating for educational purposes when we start the campaign.
Lou, you could just send that to Kelly and then she'll just send it out to everybody.
Kelly DeCaro, our clerk of the board.
Is everyone okay with getting it electronically? I don't want to challenge everybody with technology.
That's fine.
I'm sorry, everybody. I got
Oh,
to jump
okay.
off for 6 o'clock, but
That's fine, Greg. Thank you
I-
so much.
Hold on, Greg's got to get off, guys.
Hold on, Mr.
Thank you
Chairman.
very much for coming. It was very helpful. We really appreciate your time.
Great. Pleasure seeing you all again. Thank you.
Thanks, Greg.
So, Mr. Chairman, I made a motion that
No,
we,
just need a second. That we're going to move this to the full board.
I'll second it. Sterling.
All in favor? Aye.
Aye.
Opposed?
I'm going to abstain until I have a chance to look at the materials, if you don't mind. Thank you.
Okay, so as far as I know, everybody else was okay with it. Kathy?
Yeah, I'm okay. I have questions, just being in the healthcare system and seeing what it is and what it isn't. But I think it's just something new.
Mm-hmm. Oh,
And I don't know enough about it. So
absolutely true.
yeah, it's the truth, so because I'm on the other end.
Yeah.
Lou, if there are questions between now and the board, how would we get those answered?
You can email me. I can give you my email right now.
Actually, if you could put it in that packet that you send us.
Yep.
And then everybody that has questions, we could email.
And our staff RN, Kathy, is somebody named Mary Ellen Piro.
I know her.
You can talk to Mary Ellen. She's deep into this.
Okay, yeah, because I heard her speak, or she was somewhere and spoke about it. So, but if I see her, I'll stop and chat with her. Thank you.
Great.
Okay, so the motion passed, and thank you very much, Lou. I appreciate it.
I appreciate all of your time, and thank you for having us back. Very much appreciate it.
Thank you.
Thank you.
Thank you.
Are there any other questions?
Kevin has his hand up.
For Kevin? Kevin, you're muted. You're muted, Kevin.
Sorry. I just wanted to let Sarah know that we have now that we'll be advertising for these aides positions now that we've got a.
I saw an ad already posted, Kevin.
Pardon me?
I saw somebody posted something already. So
yeah, and I just want to let you know we already got an application, and this person sounds like she'd be fantastic. So we'll probably be interviewing her over the next week or so. So we did get somebody, and we're hoping to get more. So
that's great.
Thanks.
If there's no other questions, I would entertain a motion to adjourn.
So moved.
Second.
All in favor?
Hi. Good night, everybody.
Thank you.
Thank you.
Night.
good night.